Let's get started. I'm happy to introduce today's speaker, Dr. Susan Murphy. Dr. Murphy is an occupational therapist by training and professor in the Department of Physical Medicine and Rehabilitation and of Internal Medicine, Rheumatology Division at the University of Michigan. She earned her doctoral degree from Boston University and completed postdoctoral training at Yale University School of Medicine. Her research interests involve developing and translating relevant and effective interventions into practice to optimize management of chronic conditions. She has a particular interest in advancing telehealth and rehabilitation for people with scleroderma and leads the behavioral studies branch of the University of Michigan's scleroderma program. Dr. Murphy has expertise in patient-oriented and community-engaged research methods, social and behavioral clinical trial methodology, as well as real-time assessment techniques such as ecological momentary assessment and accelerometry. Thank you so much for joining us today for this fantastic webinar on TeleReach and using TeleRehab to improve hand function in scleroderma. The floor is yours, Dr. Murphy.
Great. Thanks so much, Angel. Appreciate it. And thanks to everyone who has joined us for today. I'm going to take you through some research that we've been doing on hand rehabilitation, arm rehabilitation, and talk about TeleRehab and kind of the future of what we hope to happen for hand rehab in scleroderma. So I'm going to talk a little bit about the importance of exercising to maintain hand and arm function for people with scleroderma, provide some evidence based on our research and others. And then I'd really like to get feedback on what we're doing, our direction. We have a short survey at the end, and if we have time to engage some questions and comments through the Q&A period, that would be really beneficial to us. So just to present kind of where we're at in the spectrum of treatment and management, we're really talking more about management than actively treating disease. But certainly when you see a therapist in person, there is some treatment that's happening. And you'll see some research that we have done where OTs work with people and supply treatment. But a lot of what TeleRehab does and just the mindset of getting into hand and arm exercises for function is management and what you can do to manage your mobility and your function and your symptoms like pain and swelling and other symptoms that you might have. These are things that require consistent habits and participation. So a big problem with rehab is that people do really well when they see a person. And then when they're not seeing that person anymore, they stop all the other healthy things that's related to that treatment. Like they might not do the exercises that therapists prescribe after they don't have that person to check in with anymore. And really what we're trying to get to is having people do these habits all the time. And especially for scleroderma, for hand and arm function, it's really imperative that you keep moving. It is a use it or lose it scenario here. And we'll talk about that a little more. But really we're talking about management kind of a lifelong condition. So I always am nervous when I have pictures that have hands that may look not like your hands or scary, or it's just to show that these are some things that can happen in scleroderma. Some people do develop kind of a contractured claw-like hand if they don't move regularly or just because of the disease. And some of these things that can help you promote flexibility is what we're talking about today. So if you have scleroderma, you may have some of the symptoms like pain and skin tightening. Raynaud's phenomenon is pretty much the cardinal symptom that gets people diagnosed with problems with circulation. You may have experienced digital ulcers, You can experience loss of mobility in your hands and arms, which we call contractures, and they can become fixed over time, especially if you're not doing like the mobility exercises, and things like decreased grip strength. And people tend to notice these things as they're doing activities in the moment, like it might be hard to hold on to a coffee mug or to carry objects, you find yourself dropping things. So some coordination can be reduced and some grip strength can be reduced. And when we look at the evidence, and really we're looking across kind of non-drug interventions that are done for people with scleroderma, some of our best evidence is actually for arm and hand exercises, which I call upper extremity exercises, or UE is the abbreviation I'll be using throughout these slides. So just if you see that, that's what I mean. We did a systematic review pretty recently of all the studies that we could find over the past 20 or so years to see what rehabilitation interventions were done in systemic sclerosis. And most of the studies that we found were on hand and arm exercises. Now, there were some other ones too, but our best evidence comes from these kinds of treatments. And here's an example of some of the treatments. So some of these pictures we took in our own clinic when we were doing studies, and some were supplied to us. But you'll see a combination of different types of things that people do in occupational therapy treatment. This device-looking thing over here is called a LymphaTouch, which is, or a PhysioTouch, and that's a negative pressure device that is often used when people have swelling, like lymphedema from cancer and things like that. We use that in the clinic to help pump lymph out of tissues. So it's kind of help people that have a lot of swelling. This is something that University of Michigan has in their clinic, and a lot of other clinics use for different purposes. And that's one treatment that we tested in one of our studies. You'll see people doing passive stretching, doing coordination activities like with this screw and bolt mechanism, or with the little foam blocks. And one thing that we often do in clinic and in our research is what we call like thermal modalities. So like heat packs or paraffin wax dips, which actually feel fantastic, even if you don't have scleroderma, to dip your hand in wax and then you put it in a mitt and it kind of warms up your hand. We also do things like home exercise programs. And if you've been in occupational therapy, you may have gotten an app or a paper-based program or a web-based program. There's lots of ways people receive upper extremity exercises. But a big part of treatment is doing stuff at home. So that's one thing that TeleRehab really helps with, because we have a way that you could access exercises pretty easily now that most people have smartphones or computers or tablets. Just in a real high-level summary of upper extremity rehab studies, most of the studies that have been done are small. And one reason for that is that it's often hard to get samples of people with scleroderma because it's rare. So if you're not at a specialty center or a place that sees a lot of people who have scleroderma, you tend to have small sample studies. So a lot of the studies that have been done have looked at things like feasibility of treatment, like will people show up to do the treatment? What's the participation rate? Things like that. We do know that heat, massage, and exercise are all recommended based on the evidence that was collected. Most studies focus on the hand and not on like the wrist or elbow or shoulder. So really focused on the hand impairments and not other limitations that may come up in scleroderma. And most studies were in-person treatments that, because again, scleroderma being rare, it's hard for people who don't live by a specialist or specialty center to come in for treatments. And even if you do, therapy requires repeated sessions, sometimes up to 8 8 times or more that you might be coming to a center. So it's not always feasible for people to come to in-person treatments of that intensity and frequency. And, so there's just in general access issues. So I'm going to take you through a couple of studies that we have been doing for the past, not sure, 6 or 7 years now, that have led up to this TeleReach idea. And this first study was a pilot where we just wanted to determine if there were any effects of an occupational therapy treatment to improve upper extremity function in people that already have some disease going on. So hand or arm contractures, so kind of this limited mobility, and also early diffuse cutaneous systemic sclerosis. So most of you who have scleroderma have probably heard that you may have diffuse or limited systemic sclerosis. And diffuse tends to be a little bit more of a severe course. And the early diffuse is what many of the treatments have been examined on, the early diffuse, because they think that that's kind of the time period that most people may improve. And a lot of changes may be happening in trying to stabilize the disease. It's really one of the focus groups of people. So that's where we started. And also because we could find a big enough cohort of people with this type of systemic sclerosis at University of Michigan, because we follow many people. So we did a small study with 21 people, and it was an in-person treatment where people came in for 8 weekly sessions, and we asked them to do a home exercise program at home, which was given by the therapist. And the sample was about 40 years old on average. They were mostly female, somewhat of a mix between racial and ethnic minority groups, early disease, about 3 years since diagnosis, mild or moderate disease severity, which we use the Rodnan score, which is something that the rheumatologist often assesses at visits, and all had diffuse scleroderma. And we were looking at people's perceptions of their hand and arm function. And we used the Quick Dash scale, which is a 16-item scale that asks about how you're functioning in different activities that use your hand and arms. And then the secondary outcomes were also another, the PROMIS measures, which if you're connected at all to a specialty center and they collect outcome measures, many of them use these PROMIS measures because they're very comparable across many different things that has very good measurement properties. We're just asking about your physical function. And then we had some objective tests. So we were measuring active hand motion and coordination using the 9-hole peg test. And that's a picture of the 9-hole peg test there, this little box. And what we found in these 21 people is that they did improve over time. So we followed them for 8 weeks, but we did the outcome assessments at the beginning and at mid-treatment at 4 weeks and then at 8 weeks. And we found that people did have a noticeable improvement on their Quick Dash and their physical function. And when we measured their hands with total active hand motion, we saw that they did gain motion, especially after the 4-week period. And it kind of went down a little bit at 8 weeks. Now in the peg hole test, we found that there was improvement. It was a little bit attenuated at the 8 weeks, but still we saw some improvements in objective as well as subjective measures, which was promising to us. So we wanted to kind of keep going with this. And we took about 1,000 pictures, way too many pictures of people's hands, but we did find some kind of cool ones that showed a little bit of difference for people in their motion. And these are things that you might these would be noticeable improvements in how you'd be moving your hands. And here are two participants before and after. And what we consider clinically significant is sort of a statistical thing where they compare, what threshold is kind of equal to like, how much do you really notice an improvement? And we found that almost half had these clinically significant improvements in the Quick Dash and the Promise. So again, we were pretty encouraged by these findings. So we wanted to kind of go further with this. And what we needed to do is just compare this to a comparison group, really. And that's why we do clinical trials, is we want to see if we can kind of keep a group kind of held at what they would usually do. Is this intervention really helping? Or is it just everybody is just getting better over time with no intervention? So we wanted to test it in a more rigorous kind of clinical trial design. And also we asked people to do home exercise, but we didn't really track it very well. And we didn't really have an idea of what the influence of home exercise was, which in other studies seemed to make a little bit of an effect that we wanted to look at more. So we did a study that we call the REACH study, and we were looking at offering an in-person treatment plus an app. So we really brought up our game on home exercise and made it a standardized program that could be given out to people and tailored based on people's hand and arm function. So an occupational therapist was able to tailor that for the people that were randomized into that arm. So we call that the intensive intervention, where they got the OT visits and an app. And the comparison group was just an app. So they just got the app, which I don't mean just, but only got the app, because I think it also is a good intervention. But we wanted to look at the short-term effects and longer-term effects of these two different approaches on hand disability. And again, with our same group, people that had the early diffuse scleroderma. So this is what our schema looks like, our design, where we randomize people. They came in for a baseline visit, and they were randomized either to this intense treatment or this home exercise through the app. They all got the app, but one got to see the therapist. They came in for a visit at 8 weeks, and then at 18 weeks, they came back. And the people that were randomized into the intensive group from 8 to 18 weeks, they were just monitored just like the other group. They didn't see a therapist at that point. That was just to see if they would keep doing the app. And we thought that people that were randomized into the intensive group would have better improvements compared to the app alone, which seemed to make sense. Our treatment, it was kind of following a protocol. And I think following a protocol for treatment is really important for research and for us as therapists, because if you go to one therapist in one state, you'd like to go to another therapist in another state that would be doing similar things and have some idea of what the evidence says. And it's challenging in a rare condition, because sometimes if you go to an OT in a place that's not connected with a specialty center or sees these patients, you may be the first patient they've ever seen with scleroderma. So having things like this for our health professionals are really important, which is why we wanted to have this be a protocol and have it be kind of a manual for therapists so they could learn how to treat people with scleroderma in a standardized, good way. We consulted clinical specialists on kind of the progression to this protocol, and we continue to iterate it with our clinical specialists from around the nation. And again, I think this is just really important for our evidence base. But what it looked like was that people started with these thermal modalities, so heat or paraffin wax, for a certain amount of time, which was about 15 minutes. Then we did tissue mobilization with this LymphaTouch device, which I wouldn't prescribe for everyone. I'm not a treating therapist right now, but to tell you what we found is that I think the LymphaTouch works really well if you have a lot of swelling. And if you don't have a lot of swelling, it didn't seem to help the people in our study. So that's going forward, that's not part of our protocol, but it was part of it for this study. After they did this kind of tissue mobilization, we went to mobility exercises. So passive range of motion, active range of motion. So passive range of motion is like stretching. Active range of motion is something that the person is doing by themselves, moving their fingers and wrists and all of the things. And then functional activities are things like the pictures that I showed with like the foam blocks and the screw and bolts and things like that. So there may be kind of this progression on after your hand is warmed up and you're ready to go and you do this progression. And then people are prescribed a home program that we ask people to do daily. Did I skip one? Oh no, okay. This shows you what our app looked like, and we use the PT PAL. PT stands for patient and not physical therapy, but that was just the name of their company. And basically, we had prescribed exercises that people would do, and you could go on to that day and record what you did. And there were videos that showed how to do it, and then you would record kind of how you're feeling and how difficult it was to do those activities. So we actually found kind of really interesting findings. Now this was a pretty small trial, but what we found was here we used the same measures as we did in the pilot with the quick dash and the promised physical function. The app alone is the dotted line, and the intensive intervention is the solid line. So we were really interested in what happened at 18 weeks. But when people got intensive intervention, so OT plus app, they really improved, which we expected. The app group also improved at 8 weeks, but at 18 weeks, they were about at the same place, which was really interesting to us because it really was not what we thought would happen. We thought people that just get the intensive intervention would just continue to do great, and people that got the app may or may not do great. But we found that when we gave people the app alone at the beginning, that they really treated it like it was their treatment, and they tended to do it more than people in the intensive intervention that may have thought it was more of like just a supplementary intervention. And their adherence really dropped off between week 8 and week 18. So that's kind of what we see in treatment. I mean, that's sort of what our literature base says, is that, you know, people don't tend to maintain things once they stop seeing a therapist, but here is another kind of evidence of that. But it does have implications for what people might want to do on their own, given that was they ended up at the same place with improvement. In physical function, we found that the app alone group just did a little bit better, although it's not that big of a change. And really, when we looked at their objective function, they did come back for in-person assessments. And we didn't see much of a difference, but there was some improvement in both groups. So again, we kind of came away with this app alone group being pretty good, as a pretty good treatment. And there are a lot of benefits to treatments that can reach people in a way that these in-person visits are limited. Some of the comments, it's always kind of fun to read the comments from patients, participants, and what people feel like they can do. And this is what you hope will come out of kind of being in a research study or going to treatment, is that you can use your hands better. Like this person, I can hold onto my pills now. I can open a water bottle now. I can go golfing. I can make a fist. Nobody helps me with anything. So these are some of the very real effects from participating in treatment and doing home exercises. So conclusions from this is that we saw that the Apollon group had pretty similar improvements to the intensive intervention. And we think that the intensive group relied less on the app because of the therapy. But it did give us a lot of hope that these other kinds of tele-interventions and these app-based interventions could be good tools for people that are trying to just manage their hand function and to try to maintain that. So this is where we're at now, and we're trying to plan a multi-site clinical trial for TeleReach, a TeleRehab program really based on these two previous studies, where an OT would meet virtually with participants and do kind of the same protocol. Again, they would be asked to do a little bit more without the therapist directly applying things because that's not the modality. It's really, they would be sent supplies that they could, heat up their hands. They could have all of the tools to do the functional activities and any kind of other things that the OT would ask them to do. So supplies would be sent and people would be doing these virtual visits, kind of like we're doing now with cameras and, webcams and computers or tablets, and go through a visit like that. So really the desire is to see if something like this could be scalable, so we can reach more people. Because if we can reach people in rural areas and people that need access to specialists that they can't travel to, this kind of therapy could be really important. So that's why TeleRehab to us has a lot of benefits. And especially if people are willing to use things like apps and participate in their care in those ways, this could be really useful. So Dr. Kana and I have a grant through the NIH to work with partners to try to plan a large clinical trial to test this. So we have partners from all these different specialty centers, as much as we can make it representative of the nation, with people that, rheumatologists that follow a large cohort or a cohort of patients with scleroderma. But we also are reaching out, and it's not represented here, but we're also reaching out to community clinics. And so we have like Arnold Arthritis and Rheumatology. Dr. Arnold is a rheumatologist who works in a community clinic. And we have other partners through her and through others that are connecting us to community clinics so we can really try to extend our access, not just at specialty centers, but at other places where people may be going for their care. So we're working on this planning right now, which is kind of why we wanted to do this webinar right now, is to get some feedback and thoughts about this. But our goal is that we want to get people probably with diffuse and limited scleroderma randomized into one of two conditions, which I'll show you in a minute. And everything's done remotely. So even the assessments are done remotely. And there are a lot of validated assessments that you can do virtually. You often need to see people, and so you need kind of the right setup to see people, but it's not very hard. The smartphones have good cameras, and so do laptops and things like that. But really, it's done so we don't have to have people travel into clinics. And we're thinking about an 18-week study. It may be longer because we're also very interested in maintenance effects of studies, but we are looking at TeleReach having virtual visits with an OT and a home exercise program, and having an online education program for the other group that would have a broad range of scleroderma specific self-management guidance and video. So there's two different conditions that people would get randomized into. We think assessments would occur 3 or 4 times throughout the time period, the study period. Oops. And here's my design figure. And this sort of is what we always like put in grants and stuff, but it's kind of easy to understand more graphically than just by words. But people who are eligible would either be, we would try to get rheumatologists to help refer patients to us. They would do a electronic consent and then be randomized into one of 2 arms. So the TeleReach arm or this other arm, which is kind of general symptom management, which also could be effective on some outcomes, but really we're very interested in upper extremity outcomes, which is where the OT is focused. We're not exactly sure what the OT sequence of visits is going to look like when the visits are actually going to happen. And one reason is because we're talking to policy experts to try to map it a little bit more cleanly onto billing codes for reimbursement. So we can make sure that we are testing something that could be integrated into care as easily as possible if it's effective. So we know that OTs will meet regularly with participants in this group. We just don't know when exactly that's going to occur. And then we will have baseline assessments from a blinded other OT. So blinding's like our research word for like, doesn't know what group you're assigned to, would virtually test things about your hands and arms at baseline, mid-treatment, and then like week 18. So the people that get randomized into the not TeleReach arm would get all the materials at the end, but also have a pretty robust materials throughout, just not exactly what we're doing in TeleReach. So there are some parameters to participate, and we're still kind of working out our inclusion criteria, but basically the internet connection's a really important one, having a reliable internet connection and having a tablet or computer to access the content and to attend virtual visits. We still are targeting early stage systemic sclerosis, just because that's really the time when most improvement can happen. And it's a really good time to be doing exercises. That the definition of that is 5 years or less from the time that you're diagnosed. And we think it's going to be people with diffuse or limited scleroderma, just because people with limited scleroderma have a lot of the same issues as diffuse and they would still benefit. So we'd like to have both. Okay, so this is the point of the interactive component, as interactive as we can be. But I would really like feedback. And I think we just have this Q&A portion about anyone's interest in participating in the TeleRehab program. And really, we're not trying to actively recruit right now. We're just trying to figure out if it's something that if you are a person with scleroderma, if you'd be interested in something like this. And we have this QR code that you can click on. And it's a very short survey that just asks a couple things about TeleRehab. And if you want eventually to be in a study like this, we will take your name and contact you at probably a year and a half from now when we could probably start something like this. But really what I'm interested in is kind of finding out answers to a couple questions. And I don't know. Oh yeah, here they are. Okay. So I guess the first two for people who are willing to write in the chat or do the Q&A. I'm not sure how that exactly works, but if people would be interested in participating in TeleRehab and kind of like why or why not would be really important for us to know. So we, Dr. Chen, Yan Chen and I, and Dr. Kana, we work in part of a study team where we have this planning grant, but we actually have to write like a larger grant to actually do the study. And having input from people is really important for us. So that's why we're asking so we can make this the best study possible.
Hello, Dr. Murphy, it's Angel. We do have some interest popping up in the Q&A, so I'm going to read off some of the comments, feedback. So the first kind of question that came up related to your question was, what if patients are already doing some of the modalities, such as daily dipping and the paraffin wax? And also, don't you think that all patients with hand issues could benefit past the 5-year mark?
Yes. So for the first question, it wouldn't preclude people that are already doing things like paraffin dips. It wouldn't preclude you from participating in a study such as this. It's really looking at if we give you a prescribed program, is it improving beyond what you're already feeling right now? So, paraffin wax dips are one of the components, but it would probably be something that we would just kind of incorporate. Like if you're already doing that, you would probably maybe time it before you met with a therapist if you're in that group. And if you were in the other group, you still would be doing your usual, what you usually do. And the 5-year mark is sort of arbitrary. I agree. Like, I do think people can improve past the 5-year mark. However, in some of our studies, we found some important differences with the change over time. We haven't looked at it as extensively with our hand data, but I do think focusing on a group that we think could really improve is a great start. It's like the cleanest way we can do a research study, and then we can always extrapolate in our beyond that for clinical care.
Thank you. And some other feedback we've got here is that, yes, I'm very interested. There are so many studies that aren't open to individuals with limited scleroderma, and it's affecting their hands and feet and becoming increasingly challenging. And they're very hopeful to be included in the study when it's available. Um, Another comment that came in, we have a listener from the college in Milwaukee, and they're very interested in participating in this important study to improve hand function in scleroderma.
Yeah, I think it's a great point that 2/3 of people with systemic sclerosis have the limited subtype, yet they tend to be not included in a lot of research studies because a lot of the drugs that are developed and tested really use the diffuse group as their target for function and for rehab studies. There tends to be kind of mixed groups because all people can benefit. We started with the diffuse group, but kind of soon learned that we should probably just open it up because the outcomes that we're testing are not so specific to subtype. So I am glad that we'll be able to open up the opportunity to people with limited. And, for the swelling, I'm looking at the comments too and seeing the person that has swelling. There are some things that if you follow up with me, there are some devices that are not expensive that do the same things that we used to. The picture that I showed of that big LymphoTouch device, that was like $5,000 machine. But now they have ones on Amazon that are much more within the realm of what people can buy. And they do kind of the same thing. So I know even when I was doing the LymphoTouch studies, like people were like, where can I buy this? And people did actually a couple people did actually like inquire to buy that huge expensive machine. But there are ones that are cheaper and you might be interested, the person that has swelling.
Fantastic. And this last comment here that they were diagnosed with limited scleroderma many years ago, but the hand sclerosis has only been a problem within the last 2 years. I'm assuming that they're asking related to is the trial recruiting based off of year of diagnosis or onset of symptoms?
It would be the year of diagnosis, just because that's, for research, we have to have kind of this kind of more homogeneous sample. But I do think that the stuff that we're talking about, like, is very, very important no matter where, how long ago you've been diagnosed, especially if you've been diagnosed a long time ago and are starting to experience those problems. These are really the time that you want to be doing hand and arm mobility exercises. There's so many things that you can access online. And actually the self-managed scleroderma.com, which many people know about, has some nice guidance as well that you can access. And NSF has great resources too. But I would definitely look into doing exercises if you're experiencing changes in your hands.
Thank you. And I'm sorry, I think we jumped in and did a bunch of the questions. Did you have a second question in your slides, or was that?
Oh,
Yeah.
yes. Yes. So yeah, I also wanted some thoughts from people about what they thought the benefits of TeleRehab were, or the challenges that you would have participating in TeleRehab. These are like important considerations for us as we're thinking about design of the study and how we can set up people for success if we're going to go forward with it.
Yeah, so just a quick reminder to everyone in the audience, feel free to use the chat function or the Q&A function to drop those questions in. And also there is a link to a survey, and that link to the survey is both in the chat and in the Q&A, if you'd like to fill out that short survey.
And I think so. Debbie had asked about the Amazon product, and I have my email on the last slide. If you could just email me after this, I can get you the link to that. There are several different kinds of devices for that, but I've been in touch with a couple of our clinical specialists who gave me links to them, so I could pass that along. And I do see this question of when will the study start? If you're newly diagnosed and it did not impact your hand function, are you eligible to be enrolled? So I'll answer those first. So we don't have funding to do this trial yet. So because it takes a long time in the research world, really we're talking about 2025, that this is like the most optimistic start date would be then. At University of Michigan Scleroderma program, like we're trying to do studies all the time. So you can always look back at our materials. We have a patient registry that you can join, that we reach out to people when we have new opportunities. I'm not sure exactly what the eligibility criteria will be yet, but in our last studies, people had to have some evidence of limited mobility in their hands to participate. I don't have the hand. The other question was, will I be able to provide the hand exercise program now? And I can't as part of the study. There are a lot of things online. This is not like very unique hand exercises. So there's many things that you could participate in, looking at the Scleroderma Foundation or the self-managed scleroderma.com for different exercises that you can do with your hands and arms. And it's really whatever you're going to do consistently is going to be a thing that will help. So it's not like that the exercises are magic or anything. It's just, an example.
Yeah. And we do have a few comments related to the benefits of telerehab. Christina from the audience has said that it would be one of the greatest benefits would be that people who are nowhere near centers could get access. Some people have difficulty traveling to places without support, so doing telerehab would allow them to do it from home, which I think is absolutely fantastic. Um,
Yes, thank you. That's great.
yeah. And then another comment related to that question is the advantage of telerehab is the convenience of being treated at home. There are not skilled clinics and therapists in many areas of the country, which is absolutely true. Also, will note that Dr. Murphy's email address is in the Q&A. It will be on the final slide, but it is in the Q&A at the moment, and it is also copied in the chat if you need it. Um, we do have a question here. Do any of the lymphatic devices work with contractures?
Yeah, it's not a contraindication or anything. If you have contractures, you can still try those devices. We just found when we did our trial, there were people that really enjoyed the LymphaTouch, and those were the people that had a lot of swelling, because they could feel the swelling kind of pump out of their arms, and it was like relief for them. It was kind of short term. We did a follow-up study where we actually did musculoskeletal ultrasound to look at changes after the LymphaTouch, and it was, I think, kind of a after like 24 hours. I think people don't have the same. I think you have to keep doing the LymphaTouch like probably more often than we did like a one time per week, and then we were looking at outcomes. But we found that people that had no swelling, sometimes it was a little bit painful. We thought that maybe it would break up connective tissue that's causing the tightness. So we thought, maybe that's good for everybody to use the LymphaTouch. And we didn't do formal tests of this. This is just kind of what we were feeling from looking at the people in our trial, was that it really was the people that had swollen edematous kind of extremities that really seemed to benefit from a device like the LymphaTouch, and the people that didn't have that, sometimes it was a little painful for people to use, and we didn't see any apparent benefits to those people. So that's kind of what we learned from that, but we didn't really do a lot of formal testing or anything of that. But certainly it's really gentle, like it's kind of like having a massage gun, but it like lifts up your skin instead of like presses down. Like it's not something that would be of risk to you unless you had like kind of open wounds or something. You wouldn't want to do it on that, but it's a pretty low risk kind of device to try.
Thank you. And I am curious for those individuals who don't have experience with clinical trials, and especially those that do live far away from some of these sites, what's a great way for them to kind of participate? What are some tips and tricks you'd let them know, since they might have, a year or so to wait before it's available near them?
I think just, well, joining our registry is an easy way. Emailing us. My email is here, I think. Let me see. My email is here. And feel free to email me and we can, put you on a list. The registry, if you join that, it lets you know about other things that are happening, like other kinds of studies. We do a lot of studies where we ask for feedback. So we might have people do a virtual focus group or an interview, or a survey, and they don't require coming into our center or anything. So you may hear more opportunities like that if you join the registry. But if you don't want to be on the registry and are interested in participating in this study, next year, whenever we can do it, certainly just you could email me and I can put you on a list to make sure that we contact you. Um, But either way is fine. The registry, you have to sign up like electronic consent to just give us some basic information, which just helps us figure out if you're the right person we need to contact. Like if we're doing a study with people that have limited scleroderma, if you say you have limited, we'll contact you. But if you had diffuse, we wouldn't. So things like that. But not a ton of information, but we still need a consent form for that.
Thank you. And for those individuals, I know this is a little down the road, so you may not have the answer, but for individuals who do complete the trial, will they still have access to the app and the other resources upon completion of the trial?
Yeah, yeah. So that was a benefit in our last trial. I'm not sure if we're going to do an app or have it all be online, given the provider we're working with for this next clinical trial. But when we used an app for our last study, we still have people that are using the app, and that study ended like 5 years ago. So, our intention is for you to have access to all materials. It's no good if it just sits on a shelf. For us, we want you to be able to use things.
Awesome. I think that's fantastic. Because I do think for that to be available across the country eventually is a huge goal. Hmm. Awesome. And again, for anyone in the audience, Dr. Susan Murphy's email address is on the screen. It's also in the chat and in the Q&A box. And the link to the survey, the short survey, is again in the Q&A box and in the chat. So feel free to jump in and complete that survey and drop any questions you have into the Q&A function. Um, thank you.
Thank you. And also, if anyone thinks of anything that would be challenging to be in a study like this or to do TeleRehab, we'd be very interested in knowing that. I mean, we're very excited about our research, but we also want people to critically look at it and tell us if we can do something better. So if you think of things that would prohibit you from participating or would make it more challenging, we'd love to know that as well, because we can look at that and try to see if we can address that. And actually, in these grant proposals, it's kind of nice the way that they're going. A lot of sponsors are really wanting us to talk to people that we're intending to develop interventions for, which seems obvious. It's something that we've done for many years, but they're really understanding that it's so important for us to really talk to the group that would use such an intervention. And it's so funny that many people don't ask people like if they'd want to do something like, would you want to travel in person for 8 sessions to do this? And they might write a grant and then get funding and then no one shows up. So I think the sponsors are getting wise to like, oh, we need a lot of feedback from people to really understand if it's something that they want, because nobody wants to waste their time developing something that people won't participate in. Like we know exercise is good, but we have to have it that you would actually want to do it.
Yeah, I think that's a fantastic point, Dr. Murphy. And again, that kind of goes to everyone in the audience. If this is something that, is of a lot of interest to you, or you think it may be of benefit to you or someone living with scleroderma, definitely, spread the word, because these clinical trials do heavily depend on the participation of the community members. So definitely take advantage of these trials as they're available if you believe they will be of benefit to you. And if you ever have questions related to trials, whether it be efficacy, safety, anything like that, you're always welcome to contact the centers where they're being had. You can contact the research coordinators, the physicians. You can contact staff at National Scleroderma Foundation. We're very well connected with a lot of these centers, and we're always happy to guide you throughout that process. And I see another question popped into the chat. What do the abbreviations ScD and OTR stand for? It's a great question.
Yes, that is great. And it always reminds me when I need to spell out things. So ScD is like a PhD, but it's like it's a doctor of science. So it's just some people that are OTs have an ScD just because that's where we got. I went to Boston University, that's the degree they gave out. OTR is occupational therapist registered, which means I'm registered as an OT, but I don't have the L after my name, which is licensed, which I just dropped recently, but I haven't actually treated a patient in like 20 years. I consult with clinical specialists who really know scleroderma, but I do not claim to be an expert. I am only an expert in the research aspect. Um, so when you go see a therapist, you will see people that have OTRL, and you may see people that have CHT, which is certified hand therapists. And those are really good people to see if you have scleroderma because they tend to specialize a little bit more in the hand. They have to take a lot of tests, and they are usually the people that know the most about scleroderma hands.
Think that's super useful because I know our folks see every sort of acronym after every specialist name. So knowing who the hand specialists are, I think is huge for our community members. Thank you. And we are
Yes.
coming right up at the end of time, just about. So if anyone wants to squeeze in one last question into the Q&A, you can. Kind of last call for questions. So, and while we wait for that, I definitely want to give a huge thank you to our speaker, Dr. Susan Murphy.